So next up, I'm so excited to introduce to you Dr. Heather Lau. She is a board-certified neurologist with special qualifications in child neurology. She received her Bachelor of Science with honors from Cornell and a Master's of Science in Biochemistry and Molecular Biology from New York Medical College. She went on to receive her Doctor of Medicine from University of Rochester. She trained in pediatrics at Montefiore Medical Center and completed her child neurology training as well as additional fellowship training in neurogenetics from NYU. And she's currently an assistant professor in child neurology at NYU School of Medicine and the director of the NYU Lysosomal Storage Disorders Program at NYU Langone Health. She's got a very large practice, which includes many Fabry patients as well as other lysosomal storage diseases, and is PI in many studies in a variety of indications from gene therapy to enzyme replacement therapy. So without further ado, I'm going to switch over to the slides and Dr. Heather Lau is going to take the stage.
Hello, good afternoon. Just want to make sure you can hear and or see me.
Can do both, and here are your slides.
Excellent. Thank you for driving.
Anytime.
Today. So good afternoon. We'll go to the next slide, actually. Here we go. So we'll talk about the neurologic manifestations of Fabry disease today. Here are my disclosures. I work with a variety of pharmaceutical companies and foundations to do clinical research. So next slide. And today we will talk a little bit about the effect of Fabry disease on the nervous system, but we'll specifically talk about how it affects the central nervous system versus the peripheral nervous system. But it's really important to understand what those are. And then we'll talk about the effect of Fabry on stroke risk, Fabry and white matter disease, and Fabry disease and cranial nerve 8. And we'll talk about management. So when we think about, next slide. So when we think about Fabry disease, we traditionally think about the kidney effects and the effects on the heart, but actually Fabry disease affects both the central nervous system and the peripheral nervous system. So let's define what those are. The central nervous system encompasses the brain and spinal cord, and that's one unit. And the peripheral nervous system is everything outside of that. So those nerves that come out of the spinal cord and they gather into ganglia outside that brain and spinal cord. And the peripheral nervous system actually comprises 3 subsets: the motor system, the sensory, and an autonomic nervous system. And these are all impacted by Fabry disease. Next slide. So the peripheral nervous system, in just more detail here, just pictorially showing you the motor function as well as the afferent. So when we think about nerves, right, the nerves are these long processes that connect the brain to the spinal cord to the nerves outside of there into the peripheral nervous system, and it sends messages to the muscles to do various functions, whether it's to move in this case. But it also sends messages to and from the autonomic system, and that helps us to control our sympathetic and parasympathetics, and we'll go into that in a little more detail. And so if you think about that's our outflow, we also have our tracts that pick up our sensations in the environment. So, and that brings messages back to our spinal cord and brain. So let's go to the next slide. Okay, so the autonomic nervous system, you might know it as the fight or flight system for the sympathetic division, and that is mediated by epinephrine typically. And the sympathetic division helps to dilate the pupils. It gets your heart pumping. It gets your breathing increased. It diverts blood away from your gastrointestinal tract. And it also helps with the sphincter of the bladder so that your body is ready and prepared to fight off an attack, right? It's a very primitive system. But the opposing system is the parasympathetic division, and that actually takes effect when you're at rest. So when you're sitting there and you're eating and you're digesting, then those neurotransmitters start to take over. And so they divert blood back to the GI system. It slows your heart rate down, slows your breathing down, relaxes certain smooth muscle to allow for bladder function. So if you think about it, these are opposing nervous systems, but they're both affected in Fabry disease. Next slide. So what happens with our peripheral nerves in Fabry? And so just to go back again, a little bit about anatomy so you can visualize what's going on is that your nerves are these long electrical wires. And just like an electrical wire needs insulation, right, to conduct that message, whether it's those hard, those phones, our landlines that we're used to, it conducts that message better when it's insulated. So our nerves are insulated as well with something called myelin. And we see myelin in the central nervous system and in the peripheral nervous system. And so what happens in Fabry disease, again, which is an enzyme deficiency state, it leads to accumulation of substrate or a toxin. In this case, it's GL3. And the theory is that we see this GL3 accumulation in those cells that are really critical to create that myelin wrap around those neurons. And it also deposits in the blood vessels, as you can see here in the bundle right there. There's blood vessels that feed the nerves, right? Because everything needs to have blood supply. And we find GL3 also deposits within the walls of those blood vessels. And so we feel the hypothesis is that the accumulation of GL3 narrows the vascular lumen and cuts off that oxygenated blood to the nerves. And that might be the reason for that excruciating pain that we manifest as those acroparesthesias, okay? So this occurs throughout the body. And if we look to the next slide, we can think about how that would affect systemically so many different functions. And so sometimes when we think about Fabry disease, we say it's multisystemic. And so we have peripheral nerve pain involvement, but even those sweating abnormalities. So going back to the sympathetic and the parasympathetic, sweating is mediated by the nervous system. And so that's impacted because of peripheral nervous system dysfunction. GI motility, actually, whether food and the intestinal contractions go faster or slower, are also mediated by the autonomic nervous system. And so you can have alterations in either more diarrhea or constipation due to GI dysmotility from the enteric part of the nervous system. We also see that in some peripheral nerve dysfunction in hearing and balance as well. And so it's really, truly, the nervous system is quite impacted in Fabry disease. Okay, next slide. So, when we have dysfunction, as I said, we have abnormal sweating, we can have reduced salivation and tear formation. And because we have this inability to sweat or disperse heat, we have exercise intolerance. And as I said, we had some GI dysmotility because of that dysfunction in the GI system's own nervous system. And then we can also, because it feeds, right, the autonomics feed into the heart, either accelerating heart rate or decelerating it, we can have dysrhythmias or arrhythmias that form. Next slide. So that's a little bit about peripheral nerve dysfunction. So let's move on to central nervous system dysfunction in Fabry disease. So as I said, we're talking about the brain and spinal cord. And so we actually see that same substrate, that GL3 deposition in the walls of those blood vessels feeding the brain. And the brain is very highly vascularized for a very good reason, because every single part of that brain needs to have an oxygen supply. And so the deposition in the walls leads to irregularities in those blood vessels. And it's been hypothesized that it causes local inflammation, increase in reactive oxygen species, maybe even remodeling of those walls. There might be some prothrombotic or pro-clotting factors. So those vessels are vulnerable to damage. And there's evidence actually, not just in the vessels, but in early studies looking at autopsies, that there's GL3 deposition directly in the neurons of the spinal cord, the brainstem, and certain areas of the cortex. And so what happens? How does that manifest clinically? Well, this manifests in a higher risk of stroke, or TIA, which is a transient ischemic attack or a mini stroke, as well as those white matter hyperintensities that we see on brain MRI. So we're going to delve into that a little bit more. Okay, so next slide. So what is a stroke? It's really important that all of us understand what stroke is, but specifically in our patients with Fabry disease, they are at increased risk of stroke. And so stroke is technically the sudden death, in this case, a true stroke, is death of brain cells, those neurons, due to deprivation of oxygen, either caused by blockage of blood flow, so that's ischemic, or by rupture, hemorrhagic stroke, of an artery feeding the brain. And that leads to permanent damage of that region of the brain that we can see on MRI as a specific stroke, as a specific lesion. However, what we call a mini stroke is called a transient ischemic attack. It's the same pathophysiology. There's some kind of blockage of the blood flow or rupture, but it temporarily blocks the blood flow. So more often it's ischemic, and that clot kind of sticks into that blood vessel, cuts it off briefly, and then it dissolves and goes away. It doesn't leave permanent damage, but you can still manifest symptoms for minutes to hours or even up to a day, but we don't see permanent damage on an MRI. However, a TIA, I tell my patients, is just as important to note as a stroke, because you're at risk of having permanent damage the next time that clot. So that's telling us there's some abnormalities in the cerebrovasculature, the blood vessels of the brain, that put you at risk, okay? So in Fabry, we think about these abnormal vessels prone to occlude, or they're fragile and they can rupture. But we also see stroke from cardiac reasons, right? So if you have arrhythmias and atrial fibrillation, where it's prone to creating clots, or the hypertrophy of the heart and it's not working right, can cause clots to send from the heart to the head. So that's a different process, but but if you have Fabry, classical Fabry or cardiac variant, that's another mechanism for increased stroke. Okay, next slide. So how common is stroke and Fabry disease, right? So when we look at some of the registry data, which is not, again, that's data that's input by centers who follow Fabry patients. There's some limitations to that. So we have to rely on people to enter that information. So based on the data to date, there's anywhere from 13 to 25% of patients with Fabry disease that suffer some sort of stroke or TIA event over their life course. So up to a quarter. And in the registry, the prevalence that was found to be up to 7% in men and 4% in women. More often, they're found to be ischemic strokes or TIAs, more common than hemorrhagic, but they're still hemorrhagic events. So we have to be careful. Whenever someone presents with a stroke, the first question in the emergency room is it ischemic or hemorrhagic? And that's usually sorted out by head CT. So when we look at when does this stroke occur, well, from the Fabry registry database, they found that the median age at first stroke was 39 for men and 46 for women, so a little bit later for women, but still not so much later, because we always think about women being less affected, right? But we know better now. We know that women can have just as severe disease as men. And these are the references below. Go on to the next. So it's really important to identify the symptoms of stroke for both you yourself, who's affected with Fabry, but also for family members. Strokes in Fabry can occur anywhere in the brain, just like strokes in the general population. And the brain controls everything, right? It controls thinking, language, vision, hearing, and motor function. So it can manifest in so many different symptoms. And sometimes people may not recognize what a stroke is. And it's really important that you have a high suspicion for this. And so the symptoms of that stroke are based on where in the brain it occurs. And even if it's a mini stroke, it still can have a very visible sign. So symptoms of stroke include a sudden onset of slurred speech. So you sounds like you're not articulating well, or you think you're speaking well, but everyone else around you is not understanding what you're speaking and saying, and it comes out as like garbled speech, completely unintelligible speech. Or you start to not understand people around you. So that's expressive language and receptive language problems. Now, motor function, right, can be affected. It could be as simple as an asymmetric smile. When you smile, one side of the face doesn't activate and it droops, and it could be part of the face. It could be a sudden weakness of an arm or leg, or all three. It can be confusion. It could be dizziness and vertigo. And that's important because guess what? In Fabry disease, we also have impact on our inner ear, cranial nerve 8. So is that a stroke, or is that just simply vertigo? And that has to be sorted out when it comes on acutely. by a neurologist, okay? We can also have vision loss or double vision. Strokes can also be silent. And maybe some of you have gone on to have an MRI and were surprised or shocked to have the doctor tell you that you had an old evidence of old stroke, but you never had a symptom. So it wasn't in an area of the brain that created a symptom, or it occurred while you were sleeping or silent, okay? But we can see that damage or the effects of it on MRI. So why is it important to recognize this in real time? Because if we're cutting off the brain, cutting off a part of the brain with oxygen, cutting that oxygen off, those cells can only survive a few minutes being deprived of oxygen. And so we need you to get to the hospital within a certain several-hour window, because there's still possibly a role for a clot buster, even though you have Fabry. So it still is causing vessel irregularity and clot formation, and then a doctor needs to assess whether or not you should get a medicine to dissolve that clot, or to make sure that it's not a hemorrhagic stroke that needs intervention, okay? So these are just general guidelines of symptoms of stroke, but it's the take-home point here is that we're, just like the general population that have risk factors for stroke, so do Fabry patients, okay? Next slide. So what are the predictors of recurrent stroke in Fabry patients? So in a study in 2018, they looked at risk factors in 159 genetically confirmed patients who did not have AFib, right? That would be an independent risk factor for stroke. And so they looked at the risk factors for those who went on to have recurrent stroke. And they were followed up for 5 years. So obviously the big predictor was prior stroke or TIA, so a mini stroke. Even having a mild stroke where you completely recovered, there's no damage, it's telling us that there's some irregularity in your blood vessels, and it'll put you at further stroke. Interestingly, the presence of angiokeratomas, presence of renal dysfunction, left ventricular hypertrophy, that's not so surprising, and global systolic dysfunction are independent risk factors for new onset or recurrent stroke in patients without AFib. And so, using that Fabry-specific disease severity scores were predictive using those defined risk factors. We need to do additional studies to understand this, but this was an initial study. And, they might benefit, as I said, if it's recognized early from antithrombotic therapy. Next slide. Okay, so what are other central nervous system abnormalities in Fabry? So there's something that we do see on MRI and MRA. What is that? Magnetic resonance imaging. And there's MRA, which is arterial imaging. We can see something called dolichoectasia. What is that? Those are vessels that are just simply very tortuous and dilation of these larger vessels. And when we first started seeing this, we didn't know what the implications of that were, but we did see it at a higher rate in patients with Fabry disease. We also see dilation of the basilar artery, which is in the back of the brain, one of the main feeding arteries to the back of the brain, right? And that back of the brain is really, when we have a posterior circulation stroke, that manifestation is vertigo and dizziness, right? Which can mimic a peripheral nerve problem. So is there a connection of this to stroke? Well, next slide. On some studies, there was some suggestion that it possibly, so we look at cohorts of patients and we try to compare who's had stroke and who has this. And so dolichoectasia was found in up to 13% of patients, and it was associated with older age, male sex, and hypertension, so high blood pressure. And so it was more common in patients with small strokes, old and new, and in the brainstem, right, and in the white matter. And so they were more often present, patients with dolichoectasia in general. This is in general, not just Fabry. So anyone with dolichoectasia had a higher rate with microbleeds and white matter hyperintensities, or those white matter lesions. So, dolichoectasia is associated with other imaging markers of small vessel disease. And in Fabry disease, we consider it a small vessel disease. And it's localized in the back of the brain in both young patients with TIA and ischemic stroke. So there is an association between having the presence of dilated, tortuous vessels and having stroke. Okay? So that would be an important part to look for in your screening or monitoring with a neurologist. Next. So how do we manage your risk factor, right? So preventing strokes and Fabry disease. Well, as anyone in the general public needs to reduce their stroke risk factor, it's through basically mitigating other risks, right? So reducing other pro-thrombotic or pro-stroke factors like high cholesterol. So we sometimes use statins or other ways to reduce your cholesterol. Diabetes is has an independent risk factor for developing stroke. That dysregulation of sugar control can wreak havoc on the body in so many different ways, from nerve damage, peripheral nerve damage to stroke. And so through diet and exercise, just simply reducing weight can actually reverse a pre-diabetic state. And then obviously various medications can be used to control diabetes. Blood pressure also is very important to keep that controlled. Now, what about use of aspirin or other antiplatelet or anticoagulation? So that should be discussed individually with your neurologist or cardiologist. A lot of our patients who have cardiac dysfunction are already on some sort of aspirin. So you're actually protecting your heart and you're protecting your brain. But if you're not already on an antiplatelet therapy, it's important to discuss with your neurologist in concert with your Fabry specialist about if and when you should go on it, because there's always a risk, right? If you're on antiplatelet therapy, you can bleed. You're more likely to bleed as well. So prior to your first stroke, so now at baseline, when you're diagnosed, you should talk about what are your individual risk factors, what other things are contributing, and is it time to do an aspirin or not? Now, what if you've already had evidence of a stroke? You didn't even know it, but it's on your MRI, or you've had a stroke, a clinical symptom that was found to be a stroke or TIA. Then typically at that point, you definitely start antiplatelet therapy if it was an ischemic stroke, as well as controlling the cholesterol and blood pressure and diabetes more aggressively. And so that's important to connect with a neurologist at that time. And then obviously on your cardiac status, as I mentioned before, you might already be on anticoagulation regardless because of AFib, or you have an ICD or pacemaker, okay? So what about enzyme replacement therapy or oral therapy? It's not clear that enzyme replacement therapy alters stroke risk. Again, it's a controversy of whether or not that protein can affect the brain, even though there's vessels that are probably the problematic. And then the oral therapy, Galafold or migalastat, that's an interesting concept because that's a small molecule and that can cross the blood-brain barrier. So is that going to alter your stroke risk? We don't know. It's too early to tell. That therapy's only been around for several years, and that needs to be studied, okay? So again, more data, more studies need to be done on the enzyme replacement or oral therapy. Okay, next slide. So let's talk a little bit more about this white matter. I think others have talked about it. Again, just like your peripheral nerves are wrapped in myelin or insulation, the nerve processes in your brain, the neurons in your brain have these long axons, as you can see here, that are also wrapped and insulated so that it can conduct electrochemical messages more effectively. And so when we think about white matter, it's just simply what was discovered when we did brain cutting. The white part of the brain is the insulated myelinated area, and the gray matter are the cell bodies of the neurons. And so what happens is that we can see changes in that white matter over time for many reasons, actually. There are many disorders, many diseases, many states that can cause that myelin to be damaged. And so when we do a brain MRI, we can see what they call white matter hyperintensities or unidentified white spots on the brain. They don't necessarily mean that there's a stroke, actually. It's independent of a stroke. We can see white matter changes even in the brains of patients with migraines. We can see it in patients with high blood pressure. We can see it in patients with other types of leukodystrophies or inherited diseases. So it's a non-specific finding. It's relatively normal as we age to see some white matter, but we do see white matter burden or white matter changes in Fabry disease. Next slide. So, why does it happen? There's the theory that it's from the vessel abnormalities, either leading to lack of perfusion or lack of blood supply, or on the other hand, maybe some micro bleeds. We don't know. It's, in Fabry, we think it is related to that GB3-GL3 deposition. We do see increased blood flow in the white matter correlating with this. And what's really important for all of you is, as you can see here, the white areas on this particular cut of the brain, which is cut, we're looking at an MRI down out the head. The black areas are normal fluid-filled ventricles, and those white areas are the abnormalities. White matter hyperintensities can be completely asymptomatic. It doesn't mean that there's a problem, that you can have a completely normal neurologic exam and normal cognition. You wouldn't know you had it unless you had a brain MRI. And that's very commonly seen, as I said, when people go for a brain MRI just for headache workup. But sometimes this can mislead or it can be misdiagnosed. So if you have significant white matter and you're doing fine and you happen to get a brain MRI, you don't know you have Fabry disease. I know patients that were misdiagnosed as multiple sclerosis because it looks similarly, but it's not an autoimmune disease. It can look like other leukodystrophies. And so it could be very misleading for patients, especially I've heard of patients where, they know that their son has Fabry disease, and then the mom or a female sibling goes and, well, I have MS. In actuality, you have Fabry disease causing this. And that's really important to understand. The neurologist needs to understand that we can see this. It might be an indicator, the degree. We don't have an exact measurement of how much white matter means and what that means. And so you really just always need to look at the person, because I see patients with a lot of white matter disease from other causes who are completely fine, but it's just telling us that insulation, those neurons are not well insulated, but things are still working underneath, and that's important to know. Okay, next step. So how common are white matter lesions? Should you be really alarmed and scared if you undergo your baseline MRI after diagnosis? Well, we actually see it in up to 46% of patients with FD in this one study. So 904 MRIs done, 46 studies included. And so really almost half of all patients had some kind of white matter burden. Typically the mean age was 38 years, but it ranged from even down into childhood. But it does increase with age, which we do see in the normal population as well. We do see white matter damage as we age. And up to 16% showed a significant amount of white matter. Okay, men and women were similarly affected, but we did see men being affected younger. Those with classical Fabry had a higher chance of white matter lesions compared to non-classical. I think we need to do more research in our non-classical or a cardiac and renal variant, because they're coming late to diagnosis anyway, and so it's important to understand the prevalence there. Progression or increase in white matter was seen in up to a quarter of patients in the 3-year follow-up, okay? And they were seen in patients, both men and women, with and without enzyme replacement therapy. So again, it doesn't seem to be mitigated or reduced or prevented with enzyme replacement therapy, but more studies need to be done. And what will be interesting is to see the effect on white matter burden for those patients who are on migalastat, the small molecule chaperone, okay? Next slide. So we actually can see it in children and adolescents. And again, if you don't know you're dealing with Fabry, you might be misled to think that it was pediatric MS or another type of leukodystrophy that could be severe. But they did do some brain MRI studies in 44 children, 20 boys, mean age of 14, and they were assessing for white matter lesions. And so they did see it in 16% with Fabry, had asymptomatic, so no symptoms at all. versus only 6% of controls. We did see, three patients each had 2 lesions, but they had no microbleeds, so that's really important. So no bleeding from their Fabry disease, okay? And 90% had signs or symptoms of Fabry, just to verify. Okay, next slide. Oops, you can go this way. So what does it mean? Well, there might be some relationship to stroke risk, and I think it's really an indicator of cardiac dysfunction and renal dysfunction, because we see white matter in patients without Fabry who have cardiac issues. It's really not predictive yet. It might reflect like your overall vessel health, but because they're completely asymptomatic, it's really hard to understand, because like I said, with people with migraines, we don't use that to predict whether your migraines are bad or not. It just is what it is. Does it contribute to dementia in the elderly? I don't know. We can't really extrapolate, because in patients with vascular dementia, which is distinct from Alzheimer's, the increased white matter does lead to dementia, but we don't see that frank dementia in our patients with Fabry disease. So I don't know if we can really extrapolate the data from other disease states. We need to investigate and characterize our patients with Fabry. Okay. Next slide. And this is just some more support that we don't think that ERT is really providing long-term prophylaxis of brain disease. But is it due to lateness of initiation for ERT, or is ERT just not really effectively treating the brain? Okay, just for your reference. Move on. Okay. I think there's going to be a talk about this. So again, the take-home point on this slide about memory and cognition is that in general, actual memory and intellectual functioning and cognition is relatively well preserved in Fabry, and there's other dysfunction that we're seeing. Of course, though, if you have a severe stroke, we do see dementia from severe strokes with or without Fabry disease. So that's obvious if we have large regions of the brain that are affected by a stroke, okay? And we do see comorbidities of depression, okay? Next. So again, it's basically this slide is talking about predictors of cognitive impairment, usually related to significance of the stroke, okay? And we'll keep going through here because I think this will be addressed. And memory impairment, yeah, so depression. So what I want to do right now is, here's an important, just from a neurology point of view, whenever someone complains, we say complains or endorses or describes some memory problems, the first thing I want to make sure is that you have no other reversible causes of memory issues. Sleep deprivation due to obstructive sleep apnea, even if you don't know that you snore, you don't have to snore, you can still have sleep apnea, can really mimic early memory impairment. Depression, anxiety can impact your memory. Thyroid and other metabolic factors should be explored, and medication side effects too. Okay, so you really, before you think that your memory is being impacted by anything, even with or without Fabry disease, you need to look at sleep, screen for anxiety, depression disorders. Attentional difficulty, so you have an attentional issue, that's not dementia. You're not encoding the memory because you're not attending to it. So that's really important. And attention is affected by sleep. And pain. So pain also distracts from your attention and your ability to encode a memory. And so if you are have significant pain, even though you're dealing with and coping with it, your brain is distracted. And so those are reasons for having mild memory complaints. Okay. All right, so that's my little there. Let me just comment on this. This is a very interesting area that I learned early on about cranial nerve 8. Cranial nerve 8 is a nerve that controls in your inner ear, your hearing, and your balance. And we see in Fabry disease, as you know, I'm speaking to the choir here, you know that we have hearing impairment, we have tinnitus, and we have balance problems. And some people are diagnosed with benign positional vertigo, right? So but it's actually probably a manifestation of Fabry disease. And so we see two types. We see brief and recurrent, comes on, goes off and comes on, can last minutes and occurs in up to a third. And type 2, which is longer lasting hours to days, okay? And so again, what I said earlier was that that's a peripheral nerve issue, but it does need to be distinguished. If you've had your first episode and it's very severe, you should seek neurologic help just to make sure it's not a stroke of the brain, in the back of the brain, okay? But most are benign positional vertigo type, but it is due to Fabry, okay? Next slide. So how many patients have with Fabry have neuro-otologic symptoms? Up to a quarter have hearing loss. A third almost have vertigo. And some have both. And so you can have either cochlear or vestibular dysfunction in up to 75% of our patients. And yes, so I saw a question come up. So benign positional vertigo can occur still. You have these little otoliths in your ear that get stuck in the semicircular canals, and you can do maneuvers to help with that. But sometimes if it's not going back, it could be from the nerve impulses to that. So it's worth a try, absolutely. If you have benign positional vertigo, it's worth a try to go to the ENT, the vestibular therapy, and see if their maneuvers work, if their medications work. I did a little survey last year. It's still important. It's impacting a lot of you, and some of you have success with meclizine and some other things. So it's worth a try, but it is higher prevalence in patients with Fabry. So there must be some kind of connection with that GB3. So we think it's a small fiber neuropathy. So again, small fiber nerve problem in these patients, okay? And we can further characterize that. We'll go on because I want to skip over to the next one. So it's probably multifactorial. Yeah, so it can be really impactful. I saw a comment, it can last for many months. It can be very bothersome. And so there are specialists called neuro-otologists. So they're neurologists who specialize. We have one at NYU who's fantastic. But again, it's really difficult to treat and can cause a lot of symptoms, nausea. Anytime you have a balance or vertigo, it can cause significant nausea. So you'll be using lots of different medications for that. We can talk more about that. We don't know if there's any connection again with our treatment. So if we intervene early with enzyme replacement therapy or migalastat, will we prevent that? I think we're not following it appropriately, and we should be surveying for that and seeing with our patients who are starting on therapy, do they develop it? Or if they had it and they're on therapy and they're finally on therapy, does it get better? I don't know those answers. So I really feel like we need to take a good survey of all the neurologic impacts for each of you. Okay, next. So we don't know, right? It's basically here, we're not sure if ERT is helpful. Okay, so a neurologist needs, I am a neurologist who happens to run the lysosomal storage unit for various reasons. I came to this field. So I do double duty for my patients with Fabry, but I do recommend, just like you have a cardiologist and a nephrologist for classical Fabry or whatever disease burden you have, you should have a neurologist to do periodic neurologic exams assessing for both central nervous system and peripheral nerve system dysfunction with MRIs and MRAs, if you can undergo that type of imaging, as long as you don't have any kind of cardiac device. You should have assessments for mood and cognition over time, because it may or may not be from the memory aspect. It could be from other issues. Peripheral nerve assessments, assessments of your vestibular system, as well as pain. Okay, let's go to, let's see what the next slide is, and then we need to just better define all of these manifestations and whether they respond to our therapy. Okay. So for the last few minutes, well, here, earlier diagnosis, earlier intervention, we need to find this to see if we're affecting change. So does ERT work? Does Galafold work? I've had patients with improvement of pain and GI symptoms after starting on ERT, and even with migalastat. So it was interesting. He was 18 when he started on migalastat. and he had resolution of his acroparesthesias, which he thought was the most impactful for him. Excuse me. There are definitely over-the-counter medications. There's a question that comes up that might work that are very benign. Okay, let's switch over to pain, because I want to talk a little bit more specifically about pain in Fabry disease. Trying to answer some questions as they come up, but we can also try at the end. So when we're thinking about pain in Fabry disease, it's really the crux of this talk is identifying it early and having a multimodal approach. Expectations are difficult to achieve zero pain levels in some of our patients, okay? So we'll talk a little bit about management of pain because I was requested to do so. Here are my disclosures. So again, just going back to peripheral nerve dysfunction, that's fine, we can go forward. So our pain fibers, we'll pause here while I talk. The pain fibers are sensory fibers that bring information from our environment back up to the brain. And the evolution of pain nerve fibers, they're both dull pain and sharp pain. So there's pain that's like a dull ache that you can detect, or when you step on a tack, there's a sharp pain. And there's C fibers, delta fibers. There's all these different types of fibers that bring and tell us when there's a problem in the environment. And so the idea would be we sense pain, and it causes the person to withdraw from that painful stimuli, right? So that's the idea. There's something in your environment that's hurting you and you're withdrawing from it. But what happens in Fabry disease is that our nerves itself, these are our detectors of our environment, they are firing off these fibers independent of any stimuli. So it's an aberrant, abnormal firing of neurons, telling our brain something's wrong when there's nothing wrong, right? So your body is just there and you have pain in your fingertips, you have pain in your hands and feet. And so once we figure out that there's no, toxic something going on to hurt you, we need to figure out how do we calm those nerves down? How do we stop them from sending off these signals to your brain? And that's what I want you to think about pain in Fabry, because if there's no reason for that pain, then we need to somehow reduce that stimulation of the brain, okay? So going on to the next slide. So when we think about pain, it's more of the small fibers, not the large fibers. And up to 80% of our patients, the pain starts in childhood. And it's the most common symptom reported by children with Fabry disease under the age of 5. And again, I'm telling you who are experiencing it, but neurologists need to understand the types of pain. And there can be a chronic burning pain, and there can be other shooting pains and pain crises that are triggered by exercise, heat, or overheating and fever. Okay, next slide. So, like I said, the fibers, there's many different nerve fibers in our body that detect different sensations. We have ones that detect vibration sense, and proprioception, and other fibers that detect pain. And these A delta fibers respond to mechanical pain and pinprick. So it's really important, first and foremost, when we're assessing a patient's pain, that there are no other causes for that, right? So is there comorbidity with diabetes? Diabetes can cause a chronic burning pain, and it actually can occur in the pre-diabetic state and in something called amyloidosis. But more commonly, our patients, a lot of diabetes is very common. And as a neurologist, I don't wait for diabetes. I can see nerve damage in the pre-diabetic state with very mild elevations of glucose. Glucose is toxic to your nerves. So having abnormal regulation of your glucose or your sugar, that is affecting your nerves. So that's one of the, and that's why we think, when I counsel my patients with rare diseases, and we only have so many therapies to help them, or sometimes we don't have any. What I tell my patient is the last thing you need is another reason causing pain in this case, or another reason for stroke when we're thinking about stroke risk. So diabetic control is really critical to help because now you're having different attacks on the same fibers, okay? We can even have lower tolerance to cold with these thin fiber impairment, okay? And then we have those paroxysmal, like those episodes of really radiating pain, and there's some dysautonomic features lasting hours to days, okay? Lying when you tell them you're exercising. Okay, let's move on. So what do we do to evaluate the peripheral nervous system? You go to a neurologist, they'll do some pinprick testing, temperature sensation, and to understand how you can detect or tolerate it. Yes, okay, there's a question. Can elevated glucose contribute to pain? Yes. So even if you're not fully diabetic, so it's called a pre-diabetic state, that's telling your body you're headed for the need for diabetic medication, but from a nerve standpoint, it's already doing damage. Is it day to day? No, it's the long-term accumulation of seeing sugar hitting those nerves, okay? Nerve conduction studies can be done to assess you. So those are that zapping, uncomfortable test. That tests your large fiber, so they're just looking to see if there's other fibers that are affected. There's some more invasive testing. You don't need to have this. You really, if you have a diagnosis of Fabry and you're talking about pain, we know that you have a small fiber neuropathy. So do we really need to do a nerve biopsy? I don't think at this point. It measures, we can measure how many nerve fibers are there. But really, if you have the diagnosis, we don't need to follow with that. We can even assess sweating deficiency. But for me, I just go by patient report and understand that this is the pathophysiology of the disease. Okay, but there's some fancy testing that might be done if you don't know you have Fabry, and they're trying to figure out why are your nerves firing when they're not supposed to. Okay. So management really requires a multimodal approach and not just with pain medication. It's actually, and you know this, you figure out your triggers, avoidance of triggers. The problem with medication management is the side effects from all of these medications, right? And so we have to mitigate the side effects with the pain, level of pain. We also have to think about other ways to deal with this, because pain can lead to significant changes in your mood. It can exacerbate depression, and then that depression and anxiety can exacerbate the pain level. Sleep deprivation, so you're not sleeping because you're in pain, and now sleep, that lowers your ability to cope. And so I'm a neurologist, but I think about the brain, the areas of the brain that deal with emotion, that deal with pain, that deal with, it's all one organ. And so we need to figure out how can we attack this, and we have to do it through both medication. I'm sorry, I'm laughing at the comments that are coming through. Yeah, I'm sorry that some of the neurologists are not warm and fuzzy. I'm hoping that you can find some of them that are, but it is, you need to, if you can't deal with the neurologist, right, because they're probably just diagnosing your peripheral nerve. When I'm talking about this multimodal approach, it's better probably to talk with a pain specialist at that point, because there's only so many medications and you have to start thinking outside the box, and there could be some biofeedback, there could be other what we call non-traditional approaches that could help. So we also have to think about prophylaxis prior to exercise. And if your doctor is not helping you, then find another doctor, okay? All right, next one. Next slide. Okay, so this is a little busy, but so there's different classes of drugs. So that's the first thing we start to think about is medications. And historically, interestingly, anti-epileptic medications have, they were developed to control seizures. And so they work on the central nervous system, but a lot of these medications have dual activity on the peripheral nerve system. And that's beneficial that we learned about it. So we have a long history of the side effects and dosing that's appropriate for each of these medications, because we learned about it for our seizure patients. And they're they can be very helpful in our patients with chronic pain syndrome. So carbamazepine, I'm sure most of you have heard about. It can interact with other meds. There's no renal restrictions, so that's good for our patients. And then newer generations of phenytoin is the older anti-seizure med that's been used, and the tricyclic antidepressants in low doses. So again, their indication, they're called antidepressants, but they were created for that reason, but they found out that was helpful for pain. really pain is overlapping in all aspects of your brain. So I would say that, attempting one of these or a couple of these is important to give it a fair trial too. So gabapentin and pregabalin. Again, gabapentin started out first as an anti-seizure med, then it was found to be helpful with migraines, and now it's one of our #1 meds for neuropathic pain. And so it's basically saying it takes time for it to build up. It's not, these are meds that you take, as needed when you have a pain crisis. All of these meds should be taken daily at the recommended dose and titrated upward to tolerance, and taken over weeks to months to really see a lowered pain lower pain level. Okay, so these are not for abortive therapies. And then we actually have a role for our combined serotonin and norepi reuptake inhibitors. So duloxetine and venlafaxine are so Cymbalta and Effexor, again, that can tackle some of the depressive symptoms as well as the pain symptoms. So again, there are certain risks that we have to take. Okay, cardiac restrictions for some of them, and we have to adjust for renal dysfunction. Okay, and I'm not prescribing any of these. These are just general meds that we're using, and you should talk to your doctor about it. Okay. Okay. Go next. Second line, so when you start to get beyond those first few medications, then you want to work with someone who's a specialist. I like to work with rehab physicians, rehabilitation physiatrists. They have the ability to titrate other things like lidocaine patches, topical capsaicin, if that's helpful, some prophylaxis prior to athletic activity, if there are pain crises that are localized. Let's see, opioids, we generally try to avoid. The opioid addiction crisis is very real and it's really difficult. Is there a role for cannabinoids? Again, it's hard to, it's being studied. Anecdotally, patients find relief from it. I do find it hard to get the same concentration or the same ratio from batch to batch. So, and there's special, only certain people can prescribe them. Methadone, right, we use that for opioid addiction, actually has a huge role in pain management. And other anti-epileptics, Lamictal, lacosamide have been used, as well as Botox to kind of just numb the area, basically let that area overfire, okay? Next up. NSAIDs, obviously, ibuprofen and diclofenac, tramadol, and even lidocaine for those acute pain crises. So does ERT help your pain? I'd ask you, some patients continue to suffer pain well into their on maintenance therapy. Their renal disease is arrested, is stabilized. They haven't developed further cardiac progression, but their pain persists. Some of it is thinking that there's a window of opportunity. Pain is, your neuropathic or nerve damage occurs early in childhood. And so by the time it's recognized and initiated, maybe it's too late. Those nerve fibers are just irritable and they're not, we cannot repair them. But there is some evidence from some people who started on ERT early enough where it does help their pain. So it's not an absolute yes or no here. I think it's a window of opportunity or intervention, and that goes to why we should start earlier. There's a question about the experimental enzymes. I really can't comment on whether or not the newer generation of enzymes that are being tested will help, but that's the idea, is if we can start early before we have persistent vascular compromise, a GB3 deposition, there's that window to reverse some of it. Just like in the diabetic state, the pre-diabetic state, could you potentially stop the toxic effects of glucose if we control that earlier? So the same idea. I wouldn't say it's absolutely no, but I think there's a window of opportunity. Okay, next up. Next slide. Oral chaperone, again, a big question. I'm really interested to know too, because it's a small molecule, does it penetrate better? Will it do all of these things that I say here? I don't know. We need to look at that. That remains to be seen and should be followed, actually, to see if that's helpful. I do have one case. I secured. Next slide. Yeah. So I had a case where a young man who was 18, he was diagnosed because his cousin had was on to his unfortunately, renal transplant that led to the diagnosis in him. So he was fortunately caught early, and he was 18, and he didn't know that his pain that he suffered from was from Fabry disease. So he started on megalastat. And when I interviewed him years later just to see his response over time, because when I met him, he essentially had no symptoms of Fabry disease. And so I said to him, I said, what is you can actually go forward with the slide. I said, what was the number one thing or response to Galafold? So I interviewed him at age 36. And I thought he was going to start talking about, wow, I never developed end-stage renal disease and needed a transplant like my cousin. No, his biggest impact from being on that therapy was the amelioration of his pain, which led to a huge impact on his mood and his attention. He was on ADHD meds. He was depressed. And so his pain resolved, and he also had non-specific GI symptoms that were really bothersome. He tried to avoid dairy, and his whole life was all around the bathroom too. All of those things responded to therapy. And so that's the biggest impact for him, was he started very early on it. So that's what I think of about early intervention. Okay, go forward. So management, I think about management of pain requires also management of the neuropsychological effects of chronic pain. We need to address that this chronic pain, and even having a diagnosis of a rare disease, can affect your mood, and that you're rightfully so. Reactive depression is, it's understandable, but that doesn't mean that medications are not indicated and could be helpful. I think about being just like your nerves are being hounded with toxins and causing pain. If your hippocampus are continually hit with depression, they shrink over time. There's actually physical changes due to long-term depression, and so it's a vicious cycle. And so we really need to address that, because that actually helps you cope with your pain better as well. It doesn't get rid of the pain, but it leads to more resilience and being able to adapt and cope. Okay, and so effective pain control is important, and also to help with sleep, because when you're sleep deprived, you have lower tolerance for lots of different types of things, including pain. Okay, next up. All right, so again, this is just a summary slide of saying, connect with the neurologist if you have Fabry disease, understand the burden or the disease burden on your central and peripheral nervous system. There are comments about migraines. I would be interested to know more about that. Migraines are very common in the general population, so are they increased in Fabry disease? That might be another question. I like to flip surveys over time, so that's important. Migraines can be effectively treated with lots of different, both medication and Botox and other new therapies, as well as with diet and exercise. So it's really important that we don't forget about the neurologic system. It's impacting you whether you know it or not. Most of you do know, and hopefully you can connect with a neurologist who can be sensitive and listening to you. And if not, what I typically say is, if the neurologist doesn't know Fabry, find a neurologist who's interested in learning about it, and to engage them and have them talk with your Fabry specialist to give them the background of what Fabry is, and hopefully that person will explore and learn about it and work with you to make sure that you're taken care of. Okay. Thank you so much for this time and opportunity to talk about the neurologic manifestations of on Fabry disease. Thank you.